Kia ora everyone and welcome to our Goodfellow webinar on atrial fibrillation awareness, kindly supported by the Heart Foundation. My name is Dr. Grace Lee. I'm a general practitioner and I'll be moderating the session for you tonight. Tonight we are joined by Cardiologist Guy Armstrong, cardiologist from the White Matter DHB, who will be talking upon this topic. Now I'll pass over the presentation to you, Guy.
Thank you very much, Grace. Good evening, everyone. We're talking about atrial fibrillation. This is an update on atrial fibrillation. And atrial fibrillation is hard, as you know. In cardiology, we like to keep things simple. Chest pain, angiogram, stent, discharge. Well, atrial fibrillation, as you know, is not like that. You have to tailor the management to each patient. And there's three strands to what I'm going to talk about tonight. Emphasizing that atrial fibrillation management is complex and multifaceted. Some new information that atrial fibrillation in many cases can be a lifestyle condition affected by lifestyle factors rather than just one of those things that happens to us. And some new aspects of atrial fibrillation. Now, I'm going to start off with a quiz. There's three questions that I'll be asking, and I think Grace might be asking for some sort of audience participation, but I'll start with the first question. Simple question: does exercise increase the chances of you having paroxysmal AF or reduce the chances of paroxysmal AF?
So that question's now just in progress there, Guy, and the participants are very quickly actually viewing and answering. And I'll end the polling in about 30 seconds.
It's like watching a horse race.
It is, isn't it?
Nose ahead.
Okay, shall we end the polling for that now? And now everyone can view the results there.
So that's the results, and I'm not actually going to give you the answer because the answer is contained in the body of my talk. So my thinking is that if I don't give you the answer now, you might actually stay awake for the rest of the talk. So we'll move on to the second question now. Am I allowed to move this out of the way a bit? So the Has-Bled score, you'll remember that. You've got the CHADS-VAS score and the Has-Bled score. So if you've got a high Has-Bled score, does that mean that you shouldn't anticoagulate your patient?
Okay, we'll just end the polling there now, and I'll share the results.
Good. Okay, so it looks like most people think that that's a false statement. Well, we'll see what comes out. Here's the third and final question. Following a successful AF ablation, anticoagulation is indicated for 3 months and then stops. True or false?
Okay, we'll just end that polling for you and share the results.
So most people think that's true. Okay, we'll see what what unfolds as the talk progresses.
Okay.
Can we get rid of that polling thing now, Grace?
Okay.
You can say no.
No. I just thought I had, but obviously I haven't.
Oh, it's on my screen. Maybe I can just get rid of it.
I think if you just click on the top right-hand corner in the red square, that should do it for you.
Very good. Okay, let's start off at the beginning, how to diagnose atrial fibrillation. And this is just reminding you that atrial fibrillation on the ECG is characterized by irregular RR intervals and no repeating P waves, that irregular chaotic baseline in between the irregularly spaced RR intervals. And you diagnose atrial fibrillation with a 12-lead ECG or at least a 30-second rhythm strip. Today, we've got all these fancy devices like Apple Watches that use photoplethysmography to generate a pseudo ECG rhythm. And the message there is that those devices are not accurate enough to firmly make a diagnosis of atrial fibrillation. It has to be confirmed by a conventional ECG. In fact, Apple Watches are people with Apple Watches are cluttering up cardiology waiting rooms at the moment. And in my experience, a lot of the time, the Apple Watch is wrong. There is a new category of atrial fibrillation, so-called subclinical AF, which is detected from various monitoring devices, such as pacemakers. And this is in people that don't have any symptoms, and it does seem to be a little different from the clinical atrial fibrillation, where we make a diagnosis because a patient reports symptoms. What we've learned so far, it's still a work in progress, is that atrial fibrillation from these devices, longer than 5 to 6 minutes duration, is associated with increased risk of stroke, but the risk only increases up to a high enough point for anticoagulation to be warranted if the episodes last for more than 24 hours. So that's the current state of the play with those devices, and you've probably all received reports from the pacemaker clinic saying they detected some atrial fibrillation and you're expected to do something about it. And maybe that will be a helpful guide for you. And it is a real phenomenon because over the next 2.5 years after subclinical AF, 20% of those cases will develop clinical atrial fibrillation. And so it's worth following them up and tackling the risk factors that we will talk about shortly. How common is atrial fibrillation? Well, we all know it's incredibly common. It's the commonest arrhythmia. For those of you that are aged between 50 and 55, we can say that during your remaining lifetime, the chances of you developing atrial fibrillation are 1 out of 3, which is pretty much the same as the chance of you going on to have an atherosclerotic event, such as a heart attack or angina or a stroke. So pretty common. Now, the complex multifaceted management I've broken down into 3 cogs, A, B, and C. And the A cog is the anticoagulation avoid stroke. The B cog is better symptom control. And the C cog is the comorbidities or cardiovascular risk factors, which have been coming to the fore over the last 5 years in atrial fibrillation. So, we'll divide the rest of the talk into one or other of those cogs and just try and pick out some interesting points. Just a little bit more detail, that the anticoagulation avoid stroke cog, that's all about the CHADS-VASc and the has-bled risk score to decide whether to anticoagulate. The B for better symptom control, that's when we work out how much the symptoms are impacting upon the patient's quality of life and whether we should be pursuing a rate control or a rhythm control strategy. And the cardiovascular risk factors and comorbidities, lifestyle factors, we'll talk about those too. So the ACOG, anticoagulation, just make a really basic point here that it doesn't matter what sort of atrial fibrillation you've got, whether it's paroxysmal, chronic, or whatever. It doesn't matter whether you've got atrial fibrillation or atrial flutter. The approach to anticoagulation is exactly the same. CHADS-VAS score, has-bled score. Yes, it is true that atrial fibrillation has a slightly lower risk of thromboembolism than AF, but it's not low enough to make any material difference to the way we clinically approach the situation. And the absolute contraindications to anticoagulation are few. Pretty self-evident things like active serious bleeding, a recent bleed such as an intracranial hemorrhage, platelets below 50, or severe anemia under investigation. And the point is made quite strongly that frailty, comorbidities, and increased risk of falls do not outweigh the benefits of oral anticoagulants. I think we're all in that position from time to time of thinking that we're going to do harm by putting this doddery old person having falls onto anticoagulants. But the guidelines suggest that on balance, most of these patients are going to benefit, especially from the newer agents with the lower risk of bleeding. And just to answer one of the questions from the beginning there, the has-bled score, they firmly make the point in the latest guidelines that that doesn't stop us from anticoagulating. It just reminds us to optimize the components of the has-bled score, which is blood pressure, use of non-steroidals, antiplatelet agents, and excessive alcohol.
So just to clarify there, Guy, when you're talking about the has-bled score, so for a high score, are you saying that that's not necessarily a contraindication? We just have to manage the components to it. Is that right?
Yes. Yeah. Yep.
Okay.
That's the firm message. There's no has-bled score which would stop you from anticoagulating. And what you all know already, that aspirin doesn't have any role in the current management of atrial fibrillation and preventing strokes. Just get that one out of the way. Another thing that you all know about dabigatran, one of the direct-acting oral anticoagulants, people get indigestion, reflux, acid burning, heartburn, I mean, from it. And in most patients, you can prevent that by annotating the prescription with take it with a large glass of water and stay standing for 15 minutes. So if you do that, you won't be, the patient won't be reaching for the Losec, or you won't be reaching for the rivaroxaban so much. Now, the first patient of the day comes into your room and they say, "Doctor, do you have something for piles?" They're on an anticoagulant. And so you can treat their piles, or you can see this for what it is, which is actually a very useful bit of information, a warning sign, because these direct-acting oral anticoagulants, when they cause lower GI bleeding, and they do that more commonly than warfarin, convey a markedly increased risk that the patient has colorectal cancer. Under the age of 65, the risk is 24 times. Over the age of 65, it's a 12-fold risk. So that's something useful to watch out for. Guy,
why is that? What's behind that increased risk of colorectal cancer? Do we know?
Well, I just surmise, just sort of from a priori, that they've got a lesion there, and the DOAC makes it more likely to bleed.
Well, okay, so it's already there, but it's more the revealing of the lesion in terms of the bleeding, increased bleeding risk with the DOAC. Is that right?
Yeah, I don't think there's any suggestion that they're causing colorectal cancer. No, they're just exposing it.
Very good. Thank you.
And just making the point down the bottom that the advantage of the DOACs is less intracranial bleeding, but the disadvantage is that they do cause more GI bleeding than warfarin. Okay, you got rid of that patient. You're on to the next one. Sorry, doc, I won't take anticoagulant, or I won't take rat poison, is the usual terminology. Just like they won't take statins. There is a little bit of information that may be of use to you. I'm certainly going to try it out. There is observational data that suggests anticoagulation reduces the risk of dementia. This isn't just by reducing stroke risk, because low-risk patients get the same benefit as high-risk patients. So something's going on there that's interesting. It will need to be confirmed with further studies, but for the moment, I'm going to go with that and see if I can persuade patients to take anticoagulation, because they will dement less. Good, you've sorted out that patient. Now the next one comes through the door. This is general practice, so it's pretty quick fire stuff, I understand. And this is an unusual patient. He says, "Doctor, how can I avoid another bout of AF?" So taking personal responsibility. And this is where we get on to that CCOG of the cardiovascular risk factors and comorbidities, which over the last 5 to 10 years have just become increasingly evident that these are huge factors in the genesis of atrial fibrillation and the maintenance of it. And before we talk about the cardiovascular risk factors, we'll just put up this picture of the world, and in red are the areas that have high prevalence of atrial fibrillation, and that's North America, much of Western Europe. So this atrial fibrillation is a disease of Western lifestyle, just like heart attacks and stroke is. The lowest incidence is in green, and that's in Africa and China. And yes, the same sort of risk factors for heart attack and stroke pertain to atrial fibrillation. I've picked out just a few here that are particularly pertinent to atrial fibrillation, and that's alcohol use, high blood pressure, being overweight, having sleep apnea, exercising either too much or too little. That relates to that question at the beginning. So exercise, like any treatment, has a dose-response effect. You have to have enough of it to do good, but you can get toxic levels and overdo it. And then smoking. Caffeine, there's no evidence that caffeine brings on atrial fibrillation. We all know that caffeine makes other sorts of palpitations much worse, but there doesn't seem to be any role of caffeine in atrial fibrillation. So just to drill down on the alcohol aspect, we've got a graph here, and on the x-axis, the horizontal axis is the weekly alcohol intake, 5, 10, 15, 20, and on the vertical axis is the relative risk. So the red line is the relative risk of cardiovascular mortality with alcohol intake, and you're all familiar with that U-shaped curve. A few drinks a day or a few drinks a week is better for you than no drinks, but if you have too many drinks, the risk increases of cardiovascular mortality. Contrast that with the blue line, which is the risk of atrial fibrillation, and that line increases monotonically. So there is no safe dose of alcohol if you want to minimize the chances of AF. Every glass of alcohol increases your risk of AF by a little bit. So given that fact, if I stop drinking alcohol, doctor, am I going to have less atrial fibrillation, or is it all too late? And the Australians tackled that question with a paper in the New England Journal of Medicine. They randomized 140 people with atrial fibrillation and alcohol consumption more than 10 standard drinks per week. They randomized them to just carry on with their alcohol consumption or to complete abstinence. Only 60% of the abstinent group actually managed to give up alcohol, but they all managed to reduce their consumption by about 70%. And atrial fibrillation recurrence at 6 months was only 53% in the abstinence or low alcohol intake versus 73% in the usual care, the control group. And the median percentage of time in atrial fibrillation during that 6 months was only 0.5% in the abstinence group, 1.2% in the control group. So a huge treatment effect from reducing alcohol consumption. So that's pretty exciting for those patients that want to take charge of their own health.
Now, Guy, just before we move on to the symptom control, just reflecting on some of the comorbidities, it's brought up a few questions, and I was hoping just to ask a few questions around the exercise area. Some people have just typed in wanting to know what the appropriate dose is of exercise and how much is too much.
That's a subject of controversy, but I think we can say that it seems to be endurance activities, so Ironman, marathons. I think people that have run marathons all their life, by the time they get into their 70s, almost all of them are in atrial fibrillation in my experience, and all their marathon running mates are in atrial fibrillation as well. Now, lesser degrees of exercise, we just don't know where the cut point is, and I suppose it's going to be different for different people. But the current Heart Foundation guidelines of 30 minutes of exercise 5 to 7 days a week, that's a pretty good goal to aim for. And I think it's set at that level because you're getting pretty much close to the maximum benefit of exercise. Any longer than 30 minutes, you start to tip over into musculoskeletal injuries. It may be atrial fibrillation, but we really don't know that at this stage.
Okay, all right. And I do have some questions about anticoagulation that have come up. Would you like to answer those now, or would you like to wait to the end of the session?
Hit me with them.
Okay, great. Okay. Someone is wanting a reminder as to why aspirin is not considered a suitable anticoagulant for AF.
It does reduce the risk of stroke a little bit, but not nearly as much as the 35% reduction in stroke that you get from the anticoagulants.
Okay. And looking at the different DOACs, we have a few on the market now. How would you compare one with the other, and how would you make your choice?
So my simple guide to choosing an anticoagulant is, first of all, I go with a DOAC because that has less risk of serious bleeding than warfarin. And then if it's okay to go with a DOAC, then I default to dabigatran because that has less bleeding complications than rivaroxaban, and it has a reversal agent. The things that would stop me from going with dabigatran would be the fact that it's twice daily dosing. Is that going to be an issue for this patient? And there is we've spoken about the heartburn and how to avoid that. The other factor is renal function. Dabigatran you can give to patients down to a creatinine clearance of 30 mils per minute. Rivaroxaban, as most of you are aware, has recently come down to 15 mils per minute. So that opens up the DOACs to a whole set of patients with poor renal function.
Okay. And an interesting question on, you mentioned lowering dementia risk with the DOACs. Does this apply to warfarin as well, or just the DOAC?
Good question. Don't know the answer. I'll get back to you on that one.
Fair enough. And now just going back to the slide with the risk of stroke and the length of bouts of AF, you talked about 5 to 6 minutes and over increases your stroke risk, but it was only significant of over 24 hours. Now, are you talking about this meaning individual paroxysms or runs of AF, or that have to last longer than 24 hours? Or does it have to be right the way through? Just sort of teasing out the, I guess, clarity for us thinking about people having short runs versus a longer run over that 24-hour period and deciding on when we need to anticoagulate. Or have we got that wrong?
I wish I could make it easy for you, but it's referring to continuous atrial fibrillation for 24 hours or more.
Right.
You can sort of think, well, that makes sense. You've got to be in AF for a certain period of time before clots can form. But if someone's having short bursts of half an hour atrial fibrillation multiple times per day, we do know that after reversion to sinus rhythm, some people will have this stunning of the atrium. Even though they're in sinus rhythm, the atrium isn't fully contractile. So it is conceivable that lots of short runs of AF might confer a risk of stroke. And we don't know the answer to that. We haven't got a nice, simple approach to that subclinical AF yet. Some of my colleagues would say, well, these DOACs are pretty safe, so they'd have a lower threshold for anticoagulating. And for now, I think it's a matter of clinical judgment. You look at the patient in front of you and see how risky you think a DOAC will be for that patient.
Okay, great. We do have more questions, but at this point in time, we'll let you carry on and see if we can capture some of them towards the end.
Sounds good. So the next patient is pretty anxious because I hate going into atrial fibrillation. It makes them feel anxious. So, doctor, do I need to dial 111 as soon as I get atrial fibrillation? Do I have to go straight to the hospital? What do I do? And this data here informs your answer. Along the horizontal x-axis is the hours in hospital, the hours since presenting to hospital, not the hours in AF. And on the vertical y-axis is the percent who revert to sinus rhythm. After you've been in hospital for 2 hours, 15% of patients have reverted to sinus rhythm, but by 24 hours, 60% have reverted to sinus rhythm. 48 hours, only an additional 9%. And so that data leads to the following advice. First of all, reassure the patient. They're not going to have a stroke, and they're not going to have a stroke either because they're on appropriate anticoagulant or they don't need it because their CHADS-VAS score is low. Suggest to them that they can sit it out for 24 hours and they've got a better than even chance of reverting to sinus rhythm during that time. After 24 hours, still in AF, then you need to rock up to the hospital, and the hospital's got 24 hours in which to sort you out. And that's a proven, safe strategy. Then we get on to the issue of rate control and just some simple words that you already know about the different agents that we use for rate control. Beta blocker, contraindicated in asthma, preferred if there's LV dysfunction. Diltiazem or verapamil can cause constipation and drug rash, as you know. Digoxin, said to be not as effective for rate control, but it has the advantage that it doesn't lower blood pressure. Now, there's just been a new trial called the RATE AF trial, which randomized people to bisoprolol or digoxin. and found that actually rate control with digoxin was equivalent to that with bisoprolol, and that after 6 months, quality of life was better with digoxin than bisoprolol. And I think we can intuitively see why that might be, because we've all had patients who've had their enjoyment of life sucked out of them by being on beta blockers. Often we require a combination of agents to control the rate, and just a reminder that you can't feel the radial pulse to determine what rate someone is in when they're in AF. We have to put a stethoscope at the apex and detect the heart rate that way. And a resting heart rate below 90 to 110 is associated with good outcomes in most people. That was a particular trial that showed that. I guess from my point of view, I always do a hall walk on people because my practice is skewed. I see a lot of AF patients with a rate-related cardiomyopathy, and so I'm pretty keen to know what happens to their heart rate when they walk up and down the corridor a couple of times. Onto rhythm control. An initial cardioversion is really helpful because it clarifies how much the patient likes being in sinus rhythm, and that helps to determine the subsequent management. Now, the EAST trial has recently been published, where they randomized patients to rhythm control or usual care. And the rhythm control group had fewer adverse events, hospitalization, death, stroke, and so on, than the usual care group. And one conclusion from that trial is that sinus rhythm does make a difference. It does improve outcomes. But the treatment group, the rhythm control group, had twice weekly visits with a cardiologist, whereas the usual care group just had usual care. And we all know that close clinical follow-up in the setting of clinical trials results in better outcomes. So it's not possible to tease out how much of the benefit was from the sinus rhythm and how much was from the close clinical follow-up. But at least we know that striving for sinus rhythm is not harmful. It is a reasonable option these days. And on to AF ablation. Who are we going to refer for AF ablation? Who benefits from that? These are the Auckland rules of thumb. Patients who are less than 75 years of age, those that are significantly symptomatic with their PAF, or those with an impaired left ventricle, a BMI less than 35, otherwise the risk of recurrence is just too high, and usually we trial them on one antiarrhythmic drug before going on to exposing them to the risks of ablation. How successful is it? Paroxysmal atrial fibrillation, 80 to 90% success from a single procedure, and you can go on to a second and third procedure to get that rate up really quite high. Persistent atrial fibrillation, 70 to 80% success rate. And if you've been in AF for more than 2 years, the success rate is less than 50%, so maybe don't bother. Caveat, by 5 years, fewer than 50% of patients will be free of AF. And there's no reduction in stroke. So this relates to the question at the beginning. No reduction in stroke rate. So every patient gets 3 months of anticoagulation, and then anticoagulation is determined by the patient's Jansvas score. Just a sidebar on flutter ablation, because that is different. Flutter ablation is easier and safer than AF ablation. It's just a single burn in the right atrium. Just a single burn in the right atrium. And clinically, if you don't do an ablation, flutter is more difficult to rate control. We often need all three agents, calcium channel blockers, beta blockers, and digoxin, and we still don't control the rate. So overall, there's a much lower threshold for doing a flutter ablation, but we're mindful that 30% of people with flutter go on to atrial fibrillation. But often it's still worth getting rid of the flutter because it is so hard to control the rate. And even if that leaves the patient with atrial fibrillation. There is another strategy for people who really just can't stand being in atrial fibrillation, and that's the pace and ablate strategy, where we actually ablate the AV node, cause complete heart block. So the atrium keeps fibrillating, but none of those fibrillating depolarizations get down the AV node to the ventricle. So we have to pace the right ventricle. And that does leave the patient in atrial fibrillation, even though they don't feel it and their pulse is regular from the paced rhythm, but they certainly still need anticoagulation. Who does better after ablation? Well, it's exactly the same slide as those risk factors. All those risk factors affect how likely you are to revert to atrial fibrillation after a successful ablation procedure. So it's really key to tackle those risk factors just as much as you can before embarking on the ablation strategy. Oh, and it's coming to the end. So this is how we approach patients with AF, take a history for how the AF is causing symptoms. And we look at the concomitant conditions or cardiovascular risk factors. We tot up the CHADS-VASc and the HAS-BLED score. Every patient needs a 12-lead ECG and some routine blood tests. And every patient with AF needs an echo because AF is the final common pathway for all sorts of pathology in the heart, and an echo will pick up most of that. And then that's our ABC strategy. Apply that to each patient methodically, and I think we'll get a good outcome. And that's the final slide, Grace. So I'm happy to field questions.
Okay. Now, sort of going back to thinking about our patients out there in the community of who we should be looking at in terms of risk groups, are there any particular vulnerable groups or cohorts in terms of ethnic groups that we should be keeping an eye on? And if so, what age group should we be considering these patients and checking to see if they have AF?
So this is screening for atrial fibrillation.
Correct.
And then the guidelines say we should be routinely screening every patient over the age of 75. But I think we'd all agree that we should have a lower age limit for vulnerable ethnic groups who are more prone to atrial fibrillation, whether that be due to rheumatic fever or unrecognized hypertension. Maybe 65. Not aware of any particular number. How we screen for atrial fibrillation is another. That might be quite an interesting question to put to the audience. Actually, maybe we're not set up for that. But there's different ways to screen for atrial fibrillation. In fact, feeling the patient's pulse is pretty much as sensitive as all the other techniques. It's not so specific because you do pick up people with ectopics and they turn out not to have atrial fibrillation. But a pulse check's not bad to do in every patient. Over the age of 75 or maybe 65 for vulnerable groups, then we should actually be doing a 12-lead ECG or at least a 30-second rhythm strip.
Okay, great. Thanks for that. Now, just earlier on in the beginning of your talk, you mentioned how there are particular devices such as the Apple Watch that are used to pick up particular rhythms. Now, someone is just asking, They've mentioned, well, it's not truly diagnostic. Does the FDA-approved Cardia device give better specificity than the Apple Watch?
Yes, it does. Good point. Yeah. Well, in my experience, it certainly does. I use that Cardia device all the time. Yeah.
Would you be able to expand on it? It's not something that I'm particularly familiar with, and I'm sure plenty of us, those of us in the audience, probably have had no experience with that particular device.
So it's a just a small device, and you put your thumb. I wish I had it with me here. It's about the length of my finger, and you put your thumb on each of the two electrodes and hold still while you hold your smartphone in front of the device. And I think it uses the microphone of the smartphone. I'm not exactly sure how it works, to construct an ECG over the course of about 30 seconds. And then displays that on your device, and it's quite a good quality rhythm strip ECG. And quite a few patients have purchased it. It costs a couple of $100, and then you can take your rhythm strip and email it off to your cardiologist and fill up your cardiologist inbox.
Very good.
Right.
All right. Now, we're moving back to the has-bled score. And someone has a point. Why do we have the has-bled score if there is no true contraindication? Now, you may have alluded to this in your talk, but if you could just clarify for us again, that would be great.
Yes, I was a bit disappointed to read this about the has-bled score. It's always been I've never quite got a grip on it. So really, the score itself is meaningless, is the message. And really, it's just an aid memoir to just think about the patient's risk factors.
Okay, all right. And any advice for those of us that are shifting our patients from warfarin to the DOACs in terms of what we'd normally do, in terms of, do we start it the next day after we stop warfarin, or do we wait till a particular INR occurs? What's your advice there?
Well, there's specific guidelines for that, and I hyperlink to that in one of my slides. There's some BPAC guidelines. It actually depends on whether it's rivaroxaban or dabigatran that you're changing the patient to. I think with dabigatran, you wait until the INR is less than 3, and rivaroxaban, the INR less than 2.5. So have a look at those specific guidelines, I think.
Okay, great. And are there any head-to-head studies between the two different DOACs?
No, there's not. No, and that's a very good point. So we say that dabigatran is associated with less bleeding, but that's not a head-to-head comparison.
Okay, still on the subject of medications, but moving on to the rate controlling ones. Someone has put a question through. They've used diltiazem in a patient in the past with new fast AF, but apparently it made them go into heart failure. This person's wondering, should they avoid using diltiazem in this particular scenario going forward?
Well, diltiazem and verapamil are negative inotropes. So if your ventricle's pooped to start with, then yes, you could tip them over the edge. Usually that's not the case with rapid atrial fibrillation, because any heart failure is due to the rapidity of the ventricular response. And if you slow down the ventricle, the patient feels better and is better off from the heart failure point of view, even if the slowing down has come at the expense of some negative inotropy from your diltiazem. So I think that was unlucky, and I wouldn't let that put you off next time, but maybe you've just got to make sure that the heart rate is slowing down with the diltiazem. And patients can't tolerate going too fast for too long often. So it might have just been passage of time rather than the diltiazem. So don't feel bad.
Okay, thank you. Now, with regards to the choice of beta blocker, what would you decide? Is there any particular preference between the different types of beta blockers, metoprolol, bisoprolol?
Well, bisoprolol I throw to when the patient has COPD because it's the most beta 1 selective. Asthma, my experience is if the patient truly has asthma, they're not going to tolerate a beta blocker long term, and so I generally don't even go there. Metoprolol is the sort of standard workhorse, and then carvedilol is my go-to for LV dysfunction. The MERIT trial showed that carvedilol was maybe a nose ahead of metoprolol for heart failure management, and so carvedilol is my drug of choice there, and especially if the patient has mitral regurgitation, which many heart failure patients do, because carvedilol actually dilates the arteries, which reduces afterload and helps reduce mitral regurgitation. It enables more of the stroke volume of the heart to get pumped forward into the arterial tree and less to go backwards through the mitral valve into the left atrium.
Okay. Now, someone's wanting to know, which drug do you prefer with regards to rate control? And do you prefer rate or rhythm control?
I assume you're asking personally about myself, my own atrial fibrillation. There's no preference, and I think that's a good question because it really highlights the complexities of managing atrial fibrillation. It's got to be tailored to each patient. You've got to think about each patient. There's no formula. You can't slap it on them. But LV dysfunction, beta blockers preferred. If there's no LV dysfunction, I won't go down the beta blocker route because I think that causes fatigue in many patients. I'll do the diltiazem, digoxin. I usually go for 2 agents straight away. And so
Okay.
beta blocker and digoxin, or diltiazem and digoxin. That would be my 2 standard cocktails. And that's because generally rate control is a hard thing to do. So most of the time you'll need 2 agents.
Okay. That leads me actually to a question with the digoxin. Someone's wanting to know, how often do we see GI side effects with that particular medication?
I think now that we aim for the lower end of the therapeutic range, I don't think I see side effects at all. I do use it at quite a low dose, and most elderly people, I have them on just 1 pg. The standard dose of 0.25 of digoxin, I probably only use that in people under the age of 60 who have normal renal function. And I look and listen closely for digoxin side effects, and I don't think I see them at the low doses that I use.
Okay. Now, we had 1 or 2 questions that were emailed through to us, and I just want to make sure that I know you've talked about some of them during the body read talk, but just wanted to bring 1 or 2 up to talk about now. So someone had emailed through, they've got a younger person around 55 to 65 with paroxysmal AF, and they want to keep exercising, but sometimes they get an AF attack. What is your advice? Do we talk about keeping the heart rate under a particular level? Do we encourage them to hydrate? What general advice would you suggest for this particular individual?
Okay, so that's quite a common scenario of exercise-induced atrial fibrillation. And the strategy that's most commonly used is to take a dose of something before you go out and do your exercise. That seems to be what suits most people, most athletes.
So when you mean a dose of something, what do you mean specifically?
Well, it could be a beta blocker. like a very low dose, like 25 milligrams of atenolol or 23.75 milligrams of metoprolol. And many people find that effective in preventing atrial fibrillation, but it doesn't muck up their athletic performance too much. Some people will use flecainide, take a flecainide pill before they exercise. That is a slightly riskier strategy, but that works. Ideally, you take that with another agent, such as a bit of diltiazem or a bit of a beta blocker, to prevent one-to-one conduction that can occur with flecainide. If flecainide can organize the left atrium from fibrillation into flutter. If it organizes the left atrium into flutter, flutter is 300 beats per minute, and that's slow enough that each of those beats can get conducted down the AV node, and then you've got your ventricle pumping at 300 beats per minute, and that rapidly degenerates into ventricular fibrillation. It's not an issue with the other agents because they all have properties of slowing AV conduction. Flecainide doesn't slow AV conduction, and so you have to use an additional agent such as a beta blocker or diltiazem to prevent that possibility of one-to-one flutter conduction to the ventricles. And I never use flecainide without a beta blocker or diltiazem.
Okay, now that actually leads me on to someone else's question, which is what would be your maximum dose of the old pill in the pocket for flecainide if the person had normal LV function and paroxysmal AF?
Well, the trial that was done for the pill in the pocket was 300 milligrams of rapid release flecainide, not the controlled release preparation we normally use. So 300 milligrams would be my maximum dose, and I'm a bit of a chicken. I'll generally try them on 200 milligrams.
Okay, thank you. Moving back to digoxin, we've just got a few questions coming up there. Someone's wanting to know how important is it to aim for the therapeutic level of digoxin? And I certainly remember in the old days when I was a health surgeon, I remember ordering a lot of digoxin levels. So if you could comment on that, that would be really helpful.
Well, I think they have reduced the therapeutic range down as we've recognized that people can get side effects within the old therapeutic range.
Okay.
I suppose it would be helpful to titrate to the therapeutic range, but when I think about my own practice, I don't generally tend to do that. I put them on a lowish dose and that's that.
Okay, fair enough. Now, is there any particular time frame that digoxin should be given, morning, night, and if so, why?
Well, it's given at night because then when you have your digoxin blood test the following morning, it's a trough level. So to interpret the blood levels, best given at night, blood test in the morning.
Very good. And someone's just wanting to know a little bit about the reversal agents for the DOACs and what is the availability of these in the community?
So only dabigatran in New Zealand has a reversal agent, and it's kept under haematology lock and key, and I've never had occasion to use it. So I guess I would call a haematologist from within the hospital if I wanted to use it. So I'm guessing that out there in GP land, you're going to have a hard time getting hold of it.
Fair enough. And just a final question before we wrap up for the evening. Would you recommend a cardiology visit for all new AF patients?
I definitely would. As said before, atrial fibrillation is the final common pathway for all manner of cardiac pathology. And I think it's worth teasing that out in each patient and seeing how you can optimize their management.
And do you have any last take-home points for us to practice with regards to the way we should be managing our primary care patients?
No, there was that one question about sports people having AF ablation. I think someone asked a question about how do we approach athletes with paroxysmal atrial fibrillation? Do we approach them differently? And yes, we do approach them differently these days, in that we have a lower threshold for doing an ablation on athletes, because a lot of the time they don't tolerate the medication. Also, the medication does have increased risks, and I spoke about that with flecainide. The risk of flecainide increases with the heart rate, something called use dependency. So medications are more risky in athletes, and they're more poorly tolerated. So we can go straight to an AF ablation these days without even trying antiarrhythmics in an athlete. And there was a question as to whether they could return to their athletic pursuit after a successful ablation. And of course, it doesn't matter what we say, they're going to return to it anyway. And usually that's just fine.
Great. Thank you. Thank you so much for coming on board tonight and giving us that really broad overview and update on atrial fibrillation. It's one of those things, it's very common, we need to know about it, but as you rightly pointed out, it's actually quite confusing at times. So it's nice to have some clarity points and things that we should be looking at in order to manage our patients better in the community. So thanks everyone out there for joining us tonight. Lots of lovely questions and good key topics. Thank you and good night.